All right, so thank you all for joining us. We're very lucky today. We have Amy Graham joining us. She is going to talk to us about revenue cycle management and measurement. For those of you who have rural health clinics, Amy spoke with us last summer-ish, fall, late summer.
Yes.
Late August, I think.
Yes.
And did a great job, great presentation. We had great feedback from her session. And so we wanted to open it up for all critical access hospitals. And as always, these are rather informal, so you have the opportunity to unmute yourself. I will be watching the chat as well. So if you have any questions or, hey, can you speak a little bit more on this topic, please let us know. And Amy, I'll watch the chat for you and let you know if anything pops up. So thank you all.
Super. Hey, thank you very much. I appreciate it. And I just want to say, if you did attend the training before, thank you for coming back, because as I say to people, I love talking about revenue cycle, but not everybody else loves hearing about revenue cycles. So the fact that you would come back again to talk more about this, I do appreciate that. And today I would be remiss by not saying that today is Tuesday, 2/22/22. In case you have any school-age children, I'm sure they are celebrating Tutu Day and things like that. So I do hope you are celebrating today, just for a unique day to be out there. Starting off, kicking it off, what we're going to do, our objectives of today's meeting is just really get on the same page. What is revenue cycle? Let's talk about it. Make sure that we're all saying the same lingo. And then from there, we're going to talk about some pre-claim activities. What are they? What do I mean by pre-claim activities? Why are they important? And then we'll talk about analytics. What's some cleaning meaningful data and why that's important? Not just for revenue cycle, but just measuring revenue cycle performance and for your facility as a whole. And then also we'll follow that up with some out-of-spot trends and anomalies, and then just other resources and opening it up for some Q&A. So first things first, let's get on the same page. Now, when I talk about revenue cycle management and talk to people about it, typically people think about the stages of front end, transaction processing, and back end. And they may think of one of those general areas or all of those areas, where with front end being pre-visit activities where the patient, is scheduled to come in, you're doing their insurance verification, prior authorization, and then the day where the visit occurs. And a lot of times they'll talk to this about patient access. That's what I've heard it referred to as well, when the patient is coming in, and how you're working on documenting the encounter, capturing all of the charges. And then it gets to what typically people call billing. They talk about transaction processing, where the claim is getting submitted to the payer. And you have charge entry, claim scrubbing, management, where you're working denials and appeals and resolutions. You're working with the patients on doing patient statements and collection letters, patient refunds, and things like that. So that's typically what's thought about by the claim life cycle. And with that, it's bookended by two features. One of them being the pre-claim activities, that there are actually things that are part of revenue cycle that happen before that claim is ever generated. And that's what we're going to talk about today. And then on the backside, you have the analytics to really talk about, look into how is your revenue cycle process going? Is it working pretty well, or are there problems? And how do you identify those? And you do that through the analytics side. And all of that information, and if you think about it, how to measure it, and if you're going to manage it, you need to be able to measure it. If you need to measure it, you need to define what you're going to measure. And then all of that supports different functions out there, like month-end closing. You have to have revenue cycle reports for doing that, cost reporting, compliance for coding performance management, and IT and quality. So when you think about all of the activities, when people say, what do you do now? I'm like, I'm in revenue cycle management. And that is everything related to making sure that you get paid and how do you account for that getting paid process. So it's very multifaceted when thinking about your teams and managing it, to just help your teams understand, the value that they bring to your organization. And so in those first steps and first activities, we're going to talk about pre-claim activities. What are they, and really, why are they important? And so what we want to start with is contract negotiation. So when you think about this, before you ever generate a claim out the door, you want to know how you're going to get paid and what are you going to get paid. And so that really starts with payer contracting. So when thinking about payer contracting, there is a life cycle related to payer contracting, where you do a lot of work ahead of time, where you're deciding who do you want to contract with and things like that. And then you have the initial meetings with your payers. You evaluate the contract that they give you. You may go back and have some negotiations as to how much you will accept, what they will accept. And then you have contract execution and implementation. So there's a life cycle with this payer contract. And many times, payer contract is that area that you don't really think about a lot, but there are some best practices that you really want to take into consideration when looking at these payer contracts. And so let's think about it this way, that before you walk into it, or when you get that contract back, you really want to look and see, how does this contract that you have compare to your hospital's other contracts? So if you have payer A, how does payer A's contract compare to payer B's contract? And then really looking at the assessment of the reimbursement rates. And a way to do that is look at the top 50 CPT codes by revenue and also by volume, because it could be that you have one or two codes that are out there. They're small codes, they're running through the lab, but they are your highest volume codes in your hospital. Or it could be that you have one code or one or two codes that you generate probably 100 times, not the 1,000 times that the lab would be, but they make up the majority of your revenue. So when looking at your hospital contracts, you really want to take both of those into consideration to say, what are my top 50 CPT codes by revenue and top 50 CPT codes by volume, and what is the impact for the reimbursement for those in this contract that we're looking at. Another area to look at is on your DRGs. What are your top DRGs by volume for any of your inpatient stays that you may have? If you do have some, what is that payment rate going to be out there? And making sure that your reimbursement, your contract is addressing those items. When looking at your contract and looking at the rates that they've given you, always go back and compare it to Medicare. What is the Medicare rate? Because Medicare has determined this is what it should cost to perform this test, and this is what we are going to pay you for it. It's pretty much the industry standard out there that you can compare every payer contract to, because everyone acknowledges that Medicare, they set rates, and a lot of contracts are based off of Medicare rates or a percent factor of those. You want to compare it to your cost-based reimbursements. Do you have some plans that are, that want to pay you based off of cost? What does that look like? Comparison to your Chargemaster. When you look at these fee schedules and your fee schedule in this new contract that's coming from the payer, how is that compared to your Chargemaster? Is your Chargemaster actually lower than what the fee schedule would be that the payer is giving you? Well, if that's the case, you're going to want to make sure that you address it in your Chargemaster so that you get that entire rate. Another area that I'm looking at, and this is just the competitiveness of these contracts, is that, we have pricing transparency out there. We'll talk about that in a minute. But with pricing transparency, you can actually go out and look at other hospitals in your area and see if you can find this payer that's out there. And what is the published rate that they offer to this other plan? Is the rate better than yours? Is it worse than yours? You can always use that as leverage when going back to the payer and saying, why are you paying us less than you pay hospital B down the street. We need to be paid at least that much and probably more because we are a rural hospital and that the costs are higher for us in our rural area and in our market. And then also, after you've signed these contracts and you may be going back and looking at them to say, okay, what's the financial competitiveness of it? Do we want to keep this contract? Should we reevaluate it? You want to go back and look at the prior 6 to 12 months to see what's been billed and then what they have paid you related to the contracted reimbursement rate. If they said they were going to pay you $50, are they paying you $50? Or are they paying you, say, $49 and hoping you're not going to come after them for that extra dollar? You know, go back and look at that information and evaluate the competitiveness of that payer contract. And then also go back and identify and quantify the top 10 denial reasons. You know, you may have this contract that you signed and you're like, wow, this is a fabulous contract. You know, look at these great rates that we received. But your accounts receivable team that's managing your denials and fighting it, they may come back to you and go, this is a horrible contract. They never pay us. Look how many times they may say they're going to pay us $1,000 for this claim, but they deny it as not medical necessity. And so when they're denying it for medical necessity, they may have said they're going to pay you $1,000, but at the end of the day, you didn't get paid anything. So these are areas that you really want to go back to your payer and say, hey, you're not competitive here, or you're causing me more work. Why do I have to jump through all of these hoops to get this payment that you said you would pay me in our contract that we have? So that's talking about payer contracts. And things to remember when looking at your payer contracts is that when you increase your gross charges, they don't always fall to the bottom line. So you're going to want to create a model that would project the impact of any CDM price changes by payer. So when you're looking at this payer contract to say, you know, we've got a set fee schedule, it's not going to change if we increase or decrease prices. There may be some payer contract language that you're going to want to look into. Things like excluded services that aren't going to be priced. You know, do they exclude OB services because they've got an OB center down the road that they are referring everyone to? You know, what are those OB services? Do you have OB services in your hospital and you want to make sure that you're getting paid for those? And then also look at changes in charges that trigger a lesser of clauses in the contract. And so what I mean by this is, you know, when we were talking before about your Chargemaster and where your Chargemaster may have been priced at, say, $500, but the fee schedule says $700, well, there could be a clause in your payer contract that says, we're going to pay you the lesser of those two numbers. So even though your contract says they're going to pay you $700, if your charges aren't $700, they're going to pay you whatever your charges are. And so you need to pay attention to those things and make sure that you're just aware of them and looking at that. Look at clauses that limit the annual percentage increase, making sure that it's an overall increase so that you can modify some of your departments, maybe lower some and increase others. You know, keep those things in mind. And then also look at renegotiating your existing contract. Can you actually go in and volunteer to say, hey, we're going to reduce our overall charges, but we want a higher reimbursement rate. So, you know, it's looking like they're not going to be paying as much, but maybe they are paying it because you're getting a higher percent of charges. And voluntarily say, we will give in this department that has the fewer tests that go through, so we'll lower our charges there to get a higher reimbursement on our higher volume tests so that you're really leveraging that information that's out there. And then looking at best practices, current contract statement status, best practice. My first question to you is, do you know who you're contracted with? And if you do you have a copy of the agreement? And was the agreement signed in, say, 2011? Well, 12 years, or what is that, 11 years ago? Do you have every amendment that's been signed since then? What is the most current fee schedule? Does your payment posting team have that information? Is somebody going back and doing that? As we said before, pay attention to special clauses, the lesser of clauses, and the price change notification. And the best practice also when looking at the current contract status is your timely filing deadlines versus your payment windows. Now, what do I mean by this? Well, you have a timely filing. You want to make sure that, say your payment window says that the payments will be received in 90 days on a claim. So 90 days to receive a claim. But you have a timely filing deadline that says you have 60 days with which to file a clean claim. So what happens is in that 60 days in which to file a clean claim, because you've got 30 days between the 60 days and the 90 days in which they can make a payment, they can also make a denial that says claim not accepted because it's missing information, but you aren't giving your team the chance to file that because the claims must be filed in 60 days, but the payments are received in 90 days, or the denial or the rejection will be received in 90 days, those type of things. So you want to make sure that your timely filing deadline is outside the payment window, that you will get your payment and any communication back from your payer before that timely filing deadline. And then also looking at unlisted CPT codes. How are those addressed? Are they considered, do they get paid a percent of charges? Are they not paid at all? What does that look like? So those are some best practices related to contract status and contracting. Okay, going back to our chart where we all got on the same page, the next items I want to talk about are provider credentialing, EDI enrollment, and banking setup. Now, when thinking about this, you have a provider that's hired. When your provider is hired, you begin a credentialing process that you're looking for their license and any diplomas. You want to get them enrolled at the hospital and credentialed at the hospital. So you're doing this internal credentialing process. But my question to you is, when does that information internally to your team get shared with the people who manage the payer contracts, who notify the payers that they've been enrolled? Because in many instances I've seen where a physician will get hired, they go through the whole internal hospital credentialing process, and then they start performing work, they're doing services, and as they're doing those services, the claims are getting generated, the claims get sent to the payer, and the payer sends back a notification that says, provider unable to identify provider. And what this means is that no one notified the payer that the provider had been hired. And so that payer notification and enrollment, letting them know, that really needs to be done almost as soon as the provider is hired. That when you're working through that credentialing process, also start working on the payer notification process. Within your hospital, how many people actually do this process? Is it, one person does the hospital credentialing and a different person notifies the payer? And if so, are they talking to each other to say, hey, this person was enrolled? Because I will tell you, I've worked at a large organization and I've worked at a very small organization. And it doesn't matter what size organization you work for, it's still going to take between 90 to 180 days to get the providers enrolled with the payers. It does not matter what size you are. So to think about it, a Fortune 10 company, it takes as long for them as it does for your hospital, your critical access hospital, to get enrolled with these payers. So the sooner you get that notification to the payers, letting them know that the provider is starting to work, the sooner you'll be able to receive payment on it. And then EDI enrollment and banking setup, that as part of enrolling the physician or the provider with the payer, you also want to tell the payer where to send the payment for services. Because it could be that the payer will backdate it to the date the provider was hired, or they could backdate it to the date they received the enrollment package, or it could be they just use whatever date that they approved the enrollment. So you want to make sure as soon as possible when the provider is hired, you start that payer enrollment process to make sure that you can get paid. Because at the end of the day, you're not hiring a provider. Well, you may be hiring a provider because we need to provide, or you are hiring a provider because we need to provide great patient care out there in your community, but you're not doing it for free. They're going to expect to get paid, and the way they get paid is if you get paid by the insurance companies or by the payers. So you want to make sure that you've completed all of that enrollment. So that's talking about just the banking setup, provider credentialing, and EDI enrollment. Now we're going on to CDM creation and price transparency. Now, I used to talk about these two things as separate items where I talk about the CDM, and I'm going to cover it a little bit. And now I'm talking about pricing transparency together because, you know, they're really interdependent upon one another, and especially in a critical access hospital. We used to think that pricing transparency was going to go away, but it's really not. Pricing transparency is expanding along with the No Surprises Act that is coming out, or that went into effect on January 1st of this year. And so the more education that you can give to your patients, then the better off they will be regarding the services that you provide. So when talking about a Chargemaster, I know that it's out there and it's like, what charge codes, but I really wanted to cover some of the foundational items related to it. Then you have a CPT code. That a CPT code is where the services are translated into codes that are used for billing. So the CPT HCPCS code tells the insurance company or the payer that this is the service that we provided for your insured. And with that, there is a revenue code attached to it. The revenue code helps you get your costs and charges in the correct department. So you have a revenue code for your emergency department. You have a revenue code for, say, your treatment rooms. If you have a rural health clinic, it has a separate revenue code. So it's helping you just make sure that you are associating the costs and the charges to the correct department. And then the final item that you typically find in a Chargemaster is price. And this is the charge for the procedure itself. It's the charge, not the cost of the procedure. So these are your foundational items that you have in a Chargemaster. And a lot of times, people, when you go to a department like radiology, they've got a piece of paper where they've got their charge codes that they use every day for the services that they are provided. And these are the foundational items that make up a Chargemaster. Now, within a Chargemaster, though, there are 4 key areas that you really want to make sure best practice that you are reviewing. One of those areas are those charge codes where it's missing a CPT HCPCS code, because you can have those there. You can load your Chargemaster without a CPT or HCPCS code. It's not a required field on most of them, but you want to make sure that there is a valid reason behind why there is no CPT HCPCS code. Because as I said before, that's how you tell the payer what services were provided. So you want to make sure that if you're missing any of them, you've addressed it. The next area to look at are your invalid CPT codes. Now, every year on January 1st, Medicare comes out with new CPT codes. They'll delete some, they'll inactivate some, they'll activate new ones, and they'll adjust others. And so you want to make sure that any invalid CPT HCPCS codes are addressed on an annual basis. Because I can tell you, one of 3 things is happening when a charge code has an invalid CPT code attached to it. The first thing that could be happening is that somebody is having to catch that bill and manually make the change before the claim ever goes out the door. So it hits a claim scrubber, it's an invalid CPT code, and it could be kicked back. So that's the first area that it could be caught. The second area where an invalid CPT code would be touched or that's happening with an invalid CPT code is that it's making it all the way through the claim. It makes it all the way through the payer, and the payer gets it and they say, that's an invalid code, and they send it back to you as a denial. It's not going to get paid. It'll be denied. and someone will have to work it. And then the third thing that could happen is you send an invalid CPT code through, it makes it all the way through, it doesn't get denied, it just doesn't get paid. And so the account balance will sit out there on your accounts receivable waiting for something to happen, and nothing's happening because it's an invalid CPT code. So that is one of the second area to look at. The third area to look at are those charges where you are pricing it below the Medicare fee schedule. Now, I know in critical access hospitals, a lot of people say to me, well, Amy, we get paid percent of charges. Yes, you get paid percent of charges. However, there's a patient copay up to 20% that your patients have to pay. And if you're pricing it below Medicare fee schedule, then you might not be getting all of the payments from the Medicare beneficiary that you're supposed to be getting, because Medicare is going to say, this is what their copay should be. And when you priced it below the Medicare fee schedule, you've missed that opportunity. And also, a lot of payers look at the Medicare fee schedule as their standard of reimbursement rate. And so if you are priced below Medicare fee schedule, and they have a clause in their contract that says they're going to pay you lesser of the fee schedule of your charge, that is money that you are leaving on the table. And that's actually true money, not just fake contractual adjustment money. When it's below the Medicare fee schedule, you do get paid for those items. And then the fourth area to look at are same CPT HCPCS codes that have multiple prices. So it's where you have the same procedure that's being performed, and yet it's priced differently. And a way I explain this is that I was working with a hospital. It was very interesting that you have this, but you run into a defensible pricing strategy problem when a patient, the same tech is working on it between PT and OT, and they choose the wrong code. Still a hot cold pack, not a big deal. I'm just going to choose this one over that one. But the patient could receive a service for a different price. And you know that if the patient has been coming for treatment every week and it's always $45, $45, $45, and then this week it's $35, they're going to call and be like, hey, why did I get charged $45 all these other times, but you're charging me $35 now? Or vice versa, you've charged them $35 every week, and then this week it goes up to $45, they're definitely going to call you and ask you what changed. And when you look at it and you see nothing changed, it's just a different area within the hospital, they'll be like, how can I go in that door and get that service because it's $15 cheaper? So those are areas that you want to look at when looking into your Chargemaster and making sure that you're addressing the concerns that are there. Now, key questions to ask on your Chargemaster. Do you have a defensible pricing strategy? Does your hospital have a strategy established for pricing? And is it defensible? Because now that we have pricing transparency out there, people are looking at your prices and they're going to want to know, why are you charging us 400 times what the Medicare fee schedule is? And I know you're like, Amy, really? 400 times? I just reviewed a Chargemaster the other day where the price was priced 400 times more because they had not gone through and done a Chargemaster review. So my question to you is, when was the last time your entire hospital Chargemaster was reviewed? Are you looking at this? Do you have consistent pricing? As we said before, the same CPT HCPCS with multiple prices out there and deleted codes that somebody's having to manually touch. And then, do you have an ongoing policy for establishing new procedures that engages not only the revenue cycle team for establishing the price, but the operations team for the procedures that they will be performing? What does that look like? How is it established? Is every department responsible for their own? Or is there a level of oversight and review that's done to make sure that it's consistently being produced for your hospital? And then talking about pricing transparency. Pricing transparency, this is where now you are posting your Chargemasters out there for review. And CMS requires that you do this on an annual basis and that you show that you have looked at this on an annual basis and made any changes or that it's been reviewed. And then when you review your charges for pricing transparency, to make sure that you're actually posting what your standard charges are, that you look at any negotiated rates, have they changed? And do you have any ancillary services that are new or revised? There are the standard 300 shoppable services that you need to review. Want to make sure that you're including any new services that have been added, any deleted services. And then are there any marketing needs? Do you have a marketing strategy for your department, for your hospital, where you have hired, say, a new occupational therapist? Well, your shoppable services, the 300 lists that are out there, 70 of them are required by CMS, but you could use the other 230 lines to really market that you have this new occupational therapy service there. Or do you have behavioral health services where you're now providing telehealth behavioral health, putting that information out there and really using it to use this shoppable service listing. It's required by CMS. You have to do it. Why not leverage it to meet a marketing need for your community? And then surprise billing, that you have to have good faith estimates for self-pay patients and uninsured patients that schedule services 3 days in advance. Leverage the information that's in your shoppable services to help create some of those good faith estimates and record the information that's out there. Because nothing says that you can't say, not billed by hospital, however, this is what the cost of that service is. And so using that shoppable service list to meet the need for surprise billing and the good faith estimate. And I really want to say, I've talked about all of this information with shoppable services, with CDM pricing, payer contracting, but I'd be remiss not to mention cost reporting because they really are interdependent with one another. That while I am not a cost reporting expert because it doesn't fall within revenue cycle, I do mention it because the cost report and how you all are reimbursed on your ratio of cost to charges is so interdependent upon how your charges are and what your charge structure is. And so that's your CDM pricing. And because you're now publishing it out there with the shoppable services, you want to make sure that you have a greater awareness with your community, and that when something comes up and you're like, why are you charging $400? That you change the CDM pricing, but to realize that it could impact your payer contracting and your cost reporting. So they're all working in conjunction with one another. And as I say to people, I'm showing it as a circle because we want to keep it as a circle. We don't want to turn it into an oval where one of them is getting out of whack. We want to make sure that they are all dependent upon one another and working together for this. So that's just talking about pre-claim activities, things that happen before the patient ever arrives. These are areas that you want to make sure within revenue cycle are working well, because if they're not working well, they will create downstream impact for your patient. Now, talking about analytics. So before, when we presented this, we talked about how we want to be able to measure the performance of the activities that are going on. And so in doing that, we're going to talk about our analytics piece of it. But really, it starts with clean and meaningful data. Because without clean and meaningful data, you're going to have problems. Problems are going to rise. So what happens so you've got bad, dirty data out there. Well, you've got inconsistent data that doesn't reconcile. No one understands what's going on. They don't understand the why, what's happening in the report. And when that happens, you lose team engagement. And when you lose team engagement and people aren't looking at the reporting, you have blind decision-making process where people are just like, I'm just going to go this way. I don't care what the report says. The report doesn't tie to this other report. And you have a missed opportunity to make change. And so when thinking about this, inconsistent data, without this clean and meaningful data, you've got small problems that could become bigger problems, leading to a costly situation. So for example, we have Small problems, team engagement's missing, no one understands the why, inconsistent data that doesn't reconcile. But that leads to a big problem in that you have missed opportunities to make change and a blind decision-making process. So here's my small problem. My small problem is that staffing metrics aren't monitored. No one's noticing that the coding department needs an additional FTE based on volume because no one's looking at staffing metrics. And over time, this is leading to an erosion of culture because you've got this coding department that they're like, our volume's grown. And look at all these charts that we are coding every day, or look at all of this work that we're having to touch because there's missing CPT codes. So we're having to do this volume and put this information out there and manually touch it. So over time, what's happening is that this is leading to an erosion of the culture. And you have staff that starts to turn over. And when the staff turns over, you have a lack of provider and team engagement that, they really don't care because nobody cares about me. I know I'm whining a song and I'm whining something you may already hear. Nobody cares about me. I'm so, but really what happened in this situation is that staffing metrics weren't monitored and the production volumes weren't looked at. And so when that happened, though, you had turnover and turnover expenses, and then there was a training that broke down. And so when the training broke down, it could have led to a potential Medicare False Claims Act because you had a coder, the coder was doing this process, and then they got burned out and they decided, you know what, I'm just going to leave. They brought somebody new in, and that new person was not trained to do this step that was out there that the coder had been doing. And because of that, the claims went through and you have a Medicare False Claims Act. And when that happens, that was a whole lot more expensive than it would have been to just understanding what's going on with the reporting that's out there. And so with cleaning meaningful data, what you have is that reporting is replicated on a standard cadence. So, every day they know that this is what the report's going to be, and this is what the report should show, and here's the information that's out there. And by everybody understanding that this is how the report is going to be replicated and how it's going to be and how often it's going to be generated, you have one version of the truth. And when you have one version of the truth, everyone is provided a consistent roadmap to follow. So report's done every day. They know every Monday it's going to come out, and here's what the report is saying. And then on a monthly basis, we're going to go back and look at the previous 4 weeks to see if it's growing. If it's not, there's one version of the truth, and everyone is following that one version of the truth. And then what happens is the focus shifts from questioning the data. Is this report really right? To addressing the problem. This report is right, and we need to make a hiring change. We need to hire additional staff because look how this volume has grown. And so in looking at that, your problems are identified quicker, that you're not waiting on, the staff turnover and a Medicare False Claims Act to come through, but you're actually looking at it on a week-to-week basis. And utilization and throughput can be addressed to create short and long-term efficiency improvements. Could it be that you needed to change something within the Chargemaster, that's what's broken, that's caused this inefficiency in the coding department? Or can it be that we need to hire a new team member? And so by hiring that new team member, it can improve the efficiency of the department. And then it also creates opportunities for engagement across all departments, that you start talking to each other because it's the consistent information that's out there. And so in looking at this, we want to really talk about some key indicators that help you monitor your revenue cycle performance. So you have meaningful data and some key indicators that are out there. Now, I always refer to the HFMA has actually created a MAP key initiative where they are measuring performance, applying evidence-based improvement strategies to perform to the highest standards. And there are 5 category groups: patient access, pre-billing, claims, account resolution, and financial management. Now, there are 29 different benchmarks, and you can find all of them here at this link on the HFMA's website. And what I've done on the following pages is just shared with you. Account resolution. Here, here are all of the reports that they say you should look at, and for patient access, looking at that information as well. I got some financial management measures, pre-billing managers, and claims. And I know you're saying to me, it's like, Amy, there are 29 items that really, I've got to follow all of these. I'm a 29-bed hospital or 25-bed hospital. I can't do that. I don't have a staff of 30 to be able to monitor this. So what I wanted to do is just help just break down and give you some key items to focus on, especially if you've never looked at anything before. It can be very daunting to look at all 29 of those areas. But what I want to do is give you some process measures that help you identify how the claim life cycle is working. How is the hospital and the clinic accounts receivable process performing? And then financial measures. How is your hospital or clinic performing financially related to your accounts receivable? And this is where you see it on your general ledger and your P&L. And so going with that, the reports to monitor the revenue cycle processes. This is where, when we got on the level setting and making sure we were on the same page, talking about pre-claim activities through front end, and process measures to look at your clean claim rate. What does that look like? How many claims are actually making it through to where no one is having to touch them? They're making it from the point at which the patient was discharged and final bill drop all the way through to the payer. No one had to touch it and make any intervention. That's what we consider to be a clean claim rate. Point of sale, point of service collection. Now, this is one of those that I've got to, in the future, I'm going to be presenting on just some front end measures where we talk about this because, point of service cash collections, you have the patient standing right in front of you. There's no better opportunity to start collecting the deductibles and copays that are out there. Patients now have high deductible health plans, and they have copays that are higher in nature. And rather than waiting until after the insurance company pays for those, if you collect them at the point of service cash collections, it will reduce your overall cost for trying to collect on those later, and you have the patient standing right there. Other items to look at are denial write-offs as a percent of net revenue, pre-registration rate, how many patients do you have that you're pre-registering, and then self-pay patients who are receiving financial counseling and education. So these are areas that help you manage your front-end processes. In looking at your revenue cycle, this is where you're the transaction processing through AR management. When looking at this, the areas to look at are net days and accounts receivable. Accounts receivable, AR, 90 days as a percent of the total AR. And on this one, I just want to point out that if you have any money that's out there greater than 90 days old that's related to Medicare, that's an area you really quickly ought to look at, because Medicare typically pays you within 15 days of receiving the bill. And so, at 60 days, I really start getting concerned, but at 90 days, I am definitely wanting to understand what's happening out there. Why is my accounts receivable for Medicare greater than 90 days? You also want to look at how many days do you have in total discharge status, but they've not been submitted to your payer. In other words, what this means in a different non-revenue cycle lingo is how many days after that patient's been discharged are you giving up the opportunity to get paid because you've not even submitted a bill to the payer. So, if that number's in like 5 or 6 days, that's 5 or 6 days of services that you have no chance of collecting because no one's received a bill yet. And so what does that look like? A lot of places you hear that referred to as like an acronym called DNFB, days not final, or days final bills, or days discharged but not final billed. That's what it is. Got my letters mixed up in my head. Cash collections is a percent of your net patient service revenue. Bad debt is a percent of net revenue, and your charity write-off. So this really tells you the health of your financial health of your accounts receivable. What does that look like? So we've given you these key measures for both the process measures that are out there to help you understand some key areas to look at. There are 5 on this page. And then some financial measures, another 6 on this page. 6 measures, not the 29 that was from HFMA, but just a way to really monitor it. But when doing this, you really want to, I know people ask me, Amy, how do we spot trends and anomalies? You know, if I don't even have these reports, what should I start to look at? So really, the first thing you want to do is establish a reporting cadence. Does the report generate on a daily basis, a weekly basis, monthly, quarterly, or yearly? How is that done? Because you need to stick to that established cadence, because some reports cannot be reproduced. Case in point, unapplied cash. Unapplied cash. That's where your cash has come into the bank, but it's not been applied against the accounts receivable. If you don't pull it on a daily basis, today's unapplied cash is different from tomorrow's unapplied cash, because more deposits have come in and more of those deposits are being posted to the patient account. So that's an example of a report that needs to be run on a daily basis. And it can't be reproduced. You can sort of back into it, but it's a lift to get there. You can back into it, but it'd be easier if you just ran the report every day to say how much is outstanding. So you want to make sure that you do that. And then also going back and spotting trends and anomalies, you want to have some baselines. So I've given you some examples here. The first one is just looking at a baseline where you're looking at your current period, which in this example is February 20 compared to the prior period, January 20th. And so looking at those two to say, you know, February to January, what does that look like? You can see in this example that cash collections as a percent of net patient revenue went down 15% by $7,000, 7%. And you're like, ooh, so it's an overall change of 15% going down. And you may think, is that a bad thing? I don't know. Let's look at it a different way. And you can see where your current period versus the current period prior year. So you have February of this year versus February of last year. And so you can see that cash collections actually has gone up 5% year over year. And so it's like, oh, we've had some strong cash collections. It's down, you know, we must have changed something where it's down from one year over the other. And you can see that bad debt percent, you know, that sort of changed as well, but there could be some other factors at play. And then the final one is the current period versus the prior year end, where you're looking at it to say, okay, when looking at this cash collections as a percent of net revenue, that based on December to February, it's actually up by 25%. So while we looked at this first blush to say, oh, I've got a problem here, it's gone down 15%. But really it hasn't. It's just 15% from January. So there could have been new strategies because new deductible years went into place. And you can see that the team is actually doing really well over the prior year end as well as over the prior period. And so I show this to you to just say, you want to have baselines where you're comparing it, but then you want to just investigate, that you want to say who, what, when, where, why. And then make sure you're asking why 3 times. Because, you know, when looking at this example right before, we were like, well, why is cash going down? Well, let's go look at, oh, well, why did it go up that year? That doesn't, well, oh, you can see. So it's just asking why 3 times. And then looking at the information differently. So when you look at this information, is there a specific payer that's standing out? And is this an annual trend for the payer? I've worked for a lot of companies who actually provide service in the state of Illinois. And we know about August, September of every year, the accounts receivable balances for Illinois Medicaid just start increasing. And it's like, what's going on? Why is my AR growing? It's greater than 90 days. What's happening here? Well, what we've realized is that over the years that the state of Illinois has a fiscal year that starts on October 1st. And so for about the last quarter of their fiscal year, they stopped processing payments. But we know that come October 1st, the new budget year, we will start getting paid for those services. So rather than going crazy because AR is growing, we realize that's an annual trend. We continue to monitor it, but we don't do a lot of heavy research until, say, October, because that annual trend to making sure that we will get paid. And then don't just focus on the financial areas. You need to look at the entire process, because it could be that there were operational changes that happened where someone before was doing prior authorizations in a physician's office, they were providing that information, and then all of a sudden the prior authorization denials are going up, where it's denied for medical necessity. And you're like, well, why is that happening? And it's because there was an operational change and someone's not doing that task anymore. And so you want to make sure that you look at the entire process. And then to realize that within revenue cycle, the first answer isn't the only answer, that there are multiple factors that play that can mean that there could be multiple answers. So, patient deductibles are going up, a higher health plans and things like that. And maybe you signed a different contract. And so you want to just make sure that the only payer, or the first answer isn't the only answer, and that you don't just focus on it and not take into consideration that there may be multiple factors in play. And so coming to it, that's wrapping up our information. Just to say that this process, you do have a lot of the activities that are taking place, but the key areas within pre-claims help set you up for a successful claim life process. And your analytics help you understand how to measure and monitor the performance of those areas with clean and meaningful data. And so I will just stop right now and see if anybody has any questions out there for me. If there's anything, feel free to just send it in the chat box or pop it off of mute and ask me any questions. All right. Well, I am not seeing anything at this. Oh, I have a chat coming through.
Yes. What do you use for modeling? Oh, go ahead.
It says, what do you use for modeling Blue Cross Blue Shield EAPG contracts? I'm not aware of an EAPG contract. And if I wasn't sharing my screen, I would quickly go Google that to see. Could you define that a little more? Is that EAPG pricing contracts? Hey, Ray, I'm going to do some enhanced EAPGs. Okay, thank you very much. Thank you when you're paid off of an enhanced APGs. I'm going to go back and look at that. I'm doing a lot of research right now on my APGs, and to understand why they are pricing that way, to looking at the grouping of those codes together. And I'm going to have to do some research and get back with you on that. I don't have any experience right now on modeling that, but I would definitely look into that and get you an answer back on that.
Are there any other questions folks have?
And thank you for giving me the chance to go research it, because I'm like, ooh, I'm going to go find that out.
Well, thank you, Amy, for your time. And Ray, I'll be sure to stay in touch with Amy too, and let you all know what we learned. So thank you. And our next webinar is scheduled for March. I did record today's session. As soon as we get this posted to our YouTube channel, I'll be sending it out to folks, along with information to register for our March session. With that said, thank you guys. Everyone have a great day. And thank you, Amy.
Thank you very much for letting me come and speak to you. I appreciate it. Have a great